number of cases. It's not anecdotes anymore. The case that Professor Tanner showed as well was very much similar to that 4 years, 5 years down the line, patients with advanced cancers being alive. So this is advanced bladder cancer patient who was very well and fit, presented to us, had T3B node negative disease, underwent cystectomy first, had neoadjuvant chemotherapy, followed by cystectomy, robotic cystoprostatectomy, and lymph node dissection. And afterwards, the CT scan showed a few very small lesions that initially it was only measuring 8 millimeter and non-measurable. So, but after that, the next scan actually showed significant progression. So within 6 months of neoadjuvant chemotherapy, so it's a cisplatinum refractory sort of a case, post-neoadjuvant chemotherapy and cystectomy, and was progressing. So he came in, we talked about palliative setting and metastatic disease now. He wanted to go to his son's wedding in Canada. So between July and September, the way he went in, he went away and came back, the tumor had significantly progressed. So within those 6 weeks, the lung lesions had significantly progressed. We had just opened the GO29294 study, the phase 2 trial, which 2 centers in UK contributed to. One was myself and the other was Tom Powell. So we literally just ran with that study. And it was quite a sort of a exciting study to run. So this was the baseline scan showing significant lung metastasis that was there as well. And within sort of after a few weeks of treatment, that is the first response assessment scan, we started to see some really good response in the lung metastasis. The patient tolerated it extremely well, continued on with treatment. This lesion was in June 2016, so continued to 2 years down the line. Since he started in November 14, 21 months down the line, he was still responding very well. And that is how things have remained, that multiple cysts. He had some PR bleeding, so colitis is one of the issues with this drug. So after 8-9 months of the treatment, we had to stop it for a month or two to see there was some thickening of the rectal, and then because of the symptoms, we stopped the treatment. It became completely asymptomatic. Then the treatment was restarted after discussion with the medical monitors because he was otherwise quite well, and colon biopsies had shown it to be just chronic proctitis. So after discussion with medical monitors, we restarted him on atezolizumab, and he did quite well. And more recently, last scan was in March 2018. This patient remains in remission, and this is coming to August 2018. He was started in treatment in September 2018. So really, 4 years down the line, somebody with advanced metastatic bladder cancer doing extremely well. I've got a number of cases like that we have treated in INVIGO 211 and other studies, which have shown some amazing responses and ongoing prolonged responses. There was a technology appraisal which I was involved with, NICE in UK as well as the expert witness, and they considered that it is a good option for treating locally advanced cancers. We had platinum-containing chemotherapy. They put a 2-year trigger on that it will be allowed for 2 years, and the company will provide the atezolizumab with some discount agreed. And atezolizumab meets the NICE criteria to be considered a life-extending treatment. So it's quite an exciting development that we are getting these drugs on National Health Service through these sort of platforms as well. There are uncertainties in the economical model, but cost effectiveness was maintained, comparing it with taxanes as well. So that was quite interesting. Moving forward, I think this is where hopefully things will be much more clearer in coming years. I think this was some very interesting work that was done by colleagues, including Jonathan Rosenberg and a lot of other colleagues nationally, internationally have been involved in. Matt Galaski has been involved quite a bit as well. The biomarkers outcome looking at tumor mutational burden, looking at the tumor cancer genome atlas, subtypes, and mutational load. They appear to be complementary, predicting response to chemotherapy. And again, what is quite interesting, yes, so in terms of the tumor mutational burden, urothelial cancers with higher mutational burden have higher response rate. So response of 11.6 months versus 9 months. So this is something that we put in our Lancet paper recently as well, that basically you can start to predict response with these drugs based on tumor mutational burdens as well. And this was a part of it, that if there is high tumor mutational burden, there is a clear daylight between chemotherapy versus atezolizumab. But if there is low tumor mutational burden, there is no difference. Again, these are hypothesis generating things. We need to basically confirm these things in prospective clinical trials to get a better where I will invite all of you to really, we all work together, a number of patients who are being treated in different parts of the world, to try and pool some of that data to try and get better answers in coming years. CD8 infiltration is coming out from some of the labs with some very interesting results as well, that it is associated with response to PD-L1, PD-1 blockade as well. And this is the slide that is quite important, because this is the paper in Cell from Setra, Lerner and other colleagues,